Okay, thank you, everyone. We will get started. Thank you all for being here to the webinar for non-medical use of prescription stimulants, tools for identification and prevention. If you've just joined in the last minute or so, if you could please sign into the chat with your name, place of employment, email address, and please mute yourself. A behavioral health consultant from the Michigan Opioid Collaborative will be following up with you in the coming days, and we will provide copies of this presentation as well as information you need for credits. Additionally, we have the QR code on the screen, and I will post a PDF version of this along with the survey link for all credits in the chat throughout the course of this webinar. So my name is Tim Hudson. I'm a behavioral health consultant with Michigan Opioid Collaborative. I cover the northern 21 counties of Michigan. We are a grant-funded program with the University of Michigan. We are funded by Blue Cross Blue Shield of Michigan and Michigan Department of Health and Human Services. We offer free same-day patient consultations with an addiction physician in areas such as MAT inductions and guidance, options for chronic pain, and obtaining community resources and referrals. We hold free monthly webinars and case consultations around polysubstance use and treating different substance use disorders. Additionally, we host free education and trainings tailored to your office around substance use disorders, MAT, technical assistance with office setup, and general addiction treatment. We collaborate with Great Moms Model of Care to provide support around diagnosing and treating pregnant perinatal patients with substance use disorders. And we participate in a number of community events focusing on community coalitions to build connections and work to increase awareness of substance use disorders, the benefits of medication for opioid use disorders, and reducing stigma. All right, I'll introduce our presenter. Dr. Ramachandran is an assistant professor of pharmacy administration and assistant director for the Center of Pharmaceutical Marketing and Management at the University of Mississippi School of Pharmacy. His work is aimed at identifying and improving disparities in care and health outcomes, specifically in the area of prescription drug use and healthcare quality. He is a recipient of AACP's 2019 New Investigator Award and has been involved in projects funded by the National Institute of Drug Abuse and other governmental, commercial, and nonprofit organizations for his research. The floor is yours.
Thank you, Tim. Let me share my screen. Can you see my slides okay?
Yes, we can.
Thank you very much. Well, let me first start by thanking the Michigan Opioid Collaborative and Tim for having me here. I appreciate the opportunity, and thank you all for being here. I'm hopeful that the next 40 to 45 minutes or so will be interesting and useful information for you guys. So I want to get started. Today, we will be talking about the non-medical use of prescription stimulants. And here are our learning objectives today. Oh, before we get to the learning objectives, I just want to disclose that I do not have any financial relationships or conflicts of interest related to the subject matter of this presentation. Having said that, here are some learning objectives. We will first talk about the role of stimulants in the overdose epidemic in the United States today. I will briefly go over some current research about the epidemiology of non-medical use of prescription stimulants, and then talk about two of our studies we've recently conducted that involve biases in estimation of prevalence of non-medical use of prescription stimulants, as well as the application of subtle scales for identifying malingering of ADHD. I will conclude after that with a discussion of evidence and strategies examining prevalence of non-medical use of prescription stimulant medication. Okay, before I go any further, I want us to be on the same page. So I will begin with a set of definitions, right? So for the purpose of the rest of this presentation, we will be using the term non-medical use of prescription stimulants. This will be defined as using a medication in any way not prescribed by a healthcare provider, including use of medication in doses more or less than what is prescribed, or sharing or selling of the medication, which is commonly called drug diversion, and also usage in different dosage forms than what is originally prescribed. Now, this definition is more or less the standard for non-medical use today, but please note that this is actually significantly different. Most importantly, from the ALERT working group that was published in 2013, I think that is a group of experts that came together to put together definitions for drug use and abuse and so on and so forth, but we made a conscious decision to slightly veer away from those definitions. Okay, having established the grounds, the foundations with the definition, let me talk about today's topic, right? And I will begin with this chart from the CDC, looking at trends in provisional drug overdose counts in the United States, drug overdose death counts, excuse me, in the United States between 2015 and this January. You will see here at the top of this graph is this black line, which is the drug overdose deaths involving opioid medications. And as you might expect, that overshadows almost every other drug class when it comes to overdose deaths in the US. But the two lines underneath here, the pink line showing drug overdose deaths involving cocaine and the gray line showing drug overdose deaths involving psychostimulants with abuse potential, actually have shown rapid increase between 2015 and 22. Back in 2015, the drug overdose deaths where these medications were found, these drugs were found, were less than 5,000 per year. But by 2022, some of these drug deaths are over 20,000 per year, right? And this increase is largely overshadowed by the overdose epidemic involving opioids, and rightfully so, because there are more deaths involving synthetic opioids such as fentanyl today than any other medication class. However, within that shadow, that storm with stimulants have been brewing for a long time now. The last published report involving some of these trends involving stimulants was published looking at data from between 2015 and 18. And just between those 3 years, deaths involving cocaine and methamphetamine have more than doubled. In 2008, 15% of opioid-related deaths involved a stimulant of some kind. But by 2018, that number was 35%. And between 2008 and 2018, a 1-decade period, all of the following statistics have quadrupled. This includes stimulant-related overdose deaths, stimulant-related hospital visits, and ER visits. Now, it is not entirely obvious what proportion of these overdose deaths, hospitalizations, and ED visits are contributed by prescription stimulants as opposed to illegal stimulants like cocaine or meth, for example. But as you will see me make the case over the rest of this presentation, there is adequate evidence to show that the issues related to non-medical use of prescription stimulants alone are still significant and something worth addressing. So let me first address the fact that I think the stimulant use and the non-medical use of prescription stimulants is something that has been in the shadows when compared to the opioid epidemic. If you look at media coverage of prescription stimulant use in the past decade or so, you will find very few articles that have been published in popular media addressing awareness or prevalence of these issues, right? And I compiled some of these article headlines together today to show you guys that there is something more going on, not just a lack of awareness. So for example, this 2012 article says Supermom's secret addiction was about Adderalls. This 2015 article published in Nate Silver's 538 blog shows college students aren't the only ones abusing Adderall. And if you look at the trend of these headlines, and I'll show a few more here, you'll see that they all imply that there is more happening beneath the surface with prescription stimulants, and that some of that information that is beneath the surface for these articles is well known and it is basically implied, right? Look at a few more articles here. How I hacked my brain with Adderall. A prescription pandemic, how Adderall nearly ruined my future. And traces of amphetamines being found in sewage. And then this 2016 article in the New York Times, which was a feature called Generation Adderall, talking about how young adults in high schools and colleges have been increasingly prescribed stimulant medications like Adderall and Ritalin and Vyvanse, and how they are growing to be dependent on it and are experiencing significant increasing side effects because of those medications. In 2021, Lily Allen, a singer-songwriter, I'm not sure she's an A-list celebrity, so I don't know how many of you will recognize Lily Allen, but she did open up to the press about having addiction to Adderall and talked about her own issues with that medication. Over the pandemic, with the rise of telehealth, there was growing number of new prescriptions for ADHD medications, and new articles, including this one in the New York Times, talked about the hazards of getting an online prescription for stimulant medication. Perhaps the most popular of these media exposures to the stimulant problem in this country was that Netflix documentary, which if you have not seen, I would highly recommend that you do. It's called Take Your Pills, and they basically interview several young adults who started using prescription stimulants in college and have since discovered several issues with it. The documentary does not do a good job of talking about the epidemiology or the scientific evidence. They present some really interesting and helpful anecdotes that lay the groundwork for some of our discussion today. Okay, having said that, I want to talk about some brief highlights from the research about epidemiological trends specifically related to prescription stimulants. Several studies have shown that the rates of prescribing of stimulant medication have increased in the past decade, and this is actually accompanied by rates of diagnosis of conditions like ADHD as well. Studies have also shown that this prevalence of stimulant non-medical use is actually higher among young adults who are enrolled in college compared to young adults who are not enrolled in college or other diploma-seeking programs. So that is the high-risk group for non-medical use, and we will talk about that group really for the rest of today's presentations. And when you examine that high-risk group, it is apparent why that is happening, because the motivations for this non-medical use of prescription stimulants are largely academic. Several studies, including research we have conducted, show that at least 80% or more of college students that engage in non-medical use do so for academic performance, meaning they want help staying up all night, they want help memorizing things, they want help getting better grades, and they want to deal with the academic pressures that they face in the college environment. Some other minor reasons also include partying behavior, experimentation, combination use with other substances. This last one is particularly critical in the context of the growing problem of polysubstance overdose deaths in the United States today. There have also been published articles and anecdotes where college students have used stimulant medication to increase their stamina for how much alcohol they can consume at a party, right? And these things often have very fatal consequences, such as alcohol overdose deaths. Interestingly, over 80% of college-enrolled young adults who use prescription stimulants non-medically admit just acquiring them from friends who had legitimate prescriptions for these medications. 30% of them obtained them from acquaintances. And most interestingly, about a quarter of these individuals use their own prescriptions to engage in non-medical use. And when I say engaging in non-medical use, I mean saving up these medications to take them just before exams, or perhaps using them in different dosage forms than was originally prescribed by the prescriber. Research shows that anywhere from 16 to 29% of college students have diverted their own prescriptions, which includes selling or sharing prescription medications. And a majority of students report that it is easy or somewhat easy to acquire stimulants when they need to engage in non-medical use. You will observe here that in this highlight of epidemiology that I've presented, I left out any estimates of prevalence, right? And estimating prevalence is a pretty important part of epidemiology, but I left that part out because I wanted to talk about it separately in the context of research that we have conducted. When you look at the literature, estimating prevalence of non-medical use of prescription stimulants, you will find prevalence estimates anywhere from 5% all the way up to 35%. Most literature streams agree that it is higher in college-enrolled individuals, but beyond that, there is not a lot of consensus, and you will see a lot of variation. Some of the more recent and robust research in this area, published in 2012, so really a decade ago at this point, found that by the end of 4 years, over 31% of students in colleges use stimulants without a prescription, which, as you will note, is a narrower definition than non-medical use as we are using for this presentation. But this wider definition is important to understand, because this is happening because estimating the prevalence of any sensitive behavior, like non-medical use of prescription drugs, for example, is challenging because we often have poor survey response rates and we have social desirability bias. Let me set the stage here with a hypothetical example to explain why this is happening. So here's an example of an in-person interview where an interviewer is asking a respondent a sensitive question, right? A sensitive question such as non-medical use of prescription stimulants. This is important because if you look at most published research today, including nationally representative surveys estimating prevalence of drug use, surveys like the National Survey on Drug Use and Health, the Monitoring the Future study, so on and so forth, they all estimate prevalence by asking some version of the question, have you ever engaged in this type of sensitive behavior in the past year? These questions are sensitive. They often trigger privacy concerns. among respondents. And as we know, that leads to defensive responding, dishonest responding, and social desirability bias. But as socio-behavioral researchers and health services researchers, when we have such sensitive questions in survey research, what do? Well, we simply add a sentence to a limitations section and we move on, right? Because that's what we were all trained to do for the most part. Well, we decided to dig into this a little bit and came across a technique that can help overcome some of these limitations. This is called the randomized response technique. It was originally introduced by Stanley Warner all the way back in 1965. It has since been used in some limited circumstances, but we haven't found a good study using this in the United States. So let me walk you guys through this technique, and then I will share what we found at the end of our study. In the randomized response technique, instead of asking the sensitive question directly, interviewer will ask two questions, the sensitive question and a non-sensitive dummy question. I'll give an example of this in a couple of slides, but importantly, both of these questions are yes or no questions that can be answered with a simple yes or no. And the respondent here is not directed to answer both questions, but is instructed to answer one of the two questions based on the outcome of a coin toss or any other randomizing device like that. The way this works is that the interviewer hands the respondent a coin, and then tells the individual to toss the coin. And if they come up heads, they should answer the first question. If it comes up tails, they should answer the second question. And then importantly, the interviewer actually leaves the room, allowing the respondent to flip the coin in privacy. So the individual flips the coin, notes down the result of the coin toss, puts away the coin, and then when the interviewer comes back in, the respondent then directly gives the answer, a yes or a no, without actually indicating which question was being answered. So now when the interviewer comes back into the room, they have an answer, but they don't know which question was answered because they don't know the result of the coin toss. And what this does is it virtually guarantees respondent privacy. So respondents can feel more secure in their answers. And we have observed that this is hugely impactful, even when compared to online surveys where anonymity is, more or less assured for respondents in most of today's surveys, right? Now, this methodology that I just walked you through can never be used to identify any single individual's response to that sensitive question, but we can still obtain population prevalence rates using a very simple formula that you can calculate in an Excel file on the back of an envelope even, right? The only things you need for that formula are the probability of a coin flip resulting in heads. You need to know the known probability of the non-sensitive dummy question. And then you need to know how many people said yes to the RRT question, which is the two questions combined, if you will. So with some very simple mathematics, we can work our way to a population level prevalence. Now, while I walked you through the interview methodology that was originally shared by Stanley Warner in 1965, since then, several researchers have applied this methodology to paper and pencil surveys, to online surveys, and have developed and improved this methodology. So in our study, we aimed to estimate the prevalence of non-medical use of prescription stimulants. And we said, let's compare the estimates we get from a regular direct survey methodology to an online version of the RRT called the crosswise randomized response technique. We administered the survey on campus at the University of Mississippi. We recruited about 1,200 individuals to the study. We randomized half of them to the direct self-report, where we just asked them the question, have you ever engaged in non-medical use of prescription stimulants? And then the other half was randomized to this crosswise RRT group. I'll walk you through what that group looked like. But individuals in the DSR group essentially saw both the sensitive question and our dummy question on two separate screens of this online survey. But individuals in the CRRT group did not see those two questions. They just saw the CRRT question, which looked like this. So the CRRT question, we displayed two questions on one screen of the online survey, right? The first question was, were you born in the first 10 days of your birth month? This is a non-sensitive dummy question that we had selected. Without going too far into the nuances of RRT, I will say that the choice of this dummy question is very important. And there's a lot that goes behind how you pick that one. But this is the question we picked for our study. The question B was the sensitive question we were really interested in. In the past year, have you used prescription stimulants in a way not directed by a physician? And then the respondent was told not to answer each question separately, but to compare their answers to the two questions and then tell us if their answers were the same, meaning both yes or both no, or if the answers were different, meaning one yes and the other no, or the first one no and the other one yes. So they gave us this information, and then we plugged it into that formula I showed you guys earlier, because this online adaptation of the RRT still works similar to the version I described earlier. And we found that prevalence of non-medical use in the college population was about 18.6% in the direct self-report group, but nearly double at 32.5% in the CRRT group. And those two numbers were significantly different. Our p-value was 0.003 there. So some quick implications, and then I'm going to jump to our next study really quickly. So prevalence of non-medical use of prescription stimulants on college campuses may be much higher than we've previously estimated, but it is important to remember that this methodology is applicable for most sensitive behaviors, and we need to be careful about how we estimate prevalence for these sensitive behaviors, especially in survey research. Revisiting the validity, revisiting the methodological rigor of some of these studies is very important. And finally, like I said, as health services researchers, we often conduct surveys with very, very sensitive questions in there, right? I am used to doing those. And I think we need to think about improving the validity of these estimates in our study. Quick note about the RRT, it has a lot of advantages. It is flexible, it improves the validity of estimation, but it does have some downsides. It adds some random noise to your survey estimation, which means that your sample size requirements are higher when you use RRT, and your statistical analysis is going to be slightly more complex because it's not just a percentage for prevalence estimation anymore. Having said that, I'm going to quickly switch gears and talk about estimating validity of ADHD diagnoses. Why are we talking about ADHD diagnosis validity? Because I mentioned earlier that if you look at the epidemiology of non-medical use of prescription stimulants, most individuals on college campuses actually say that obtaining stimulants is easy, and we know that lifetime rates of drug diversion of legitimate prescriptions is also high. And given we know that the rates of these legitimate stimulant prescriptions for ADHD are increasing, we need to ask ourselves, what is the validity of ADHD diagnoses conducted in clinical assessments? I want to first begin this discussion by saying ADHD is bimodal, right? There is a significant problem with ADHD, both with underdiagnosis and with overdiagnosis. Underdiagnosis happens in the college population because mental illnesses, learning disabilities may still be seen as taboo. Often individuals do not recognize that their conditions warrant clinical assessment and that they need to seek out help with their learning disabilities. So underdiagnosis is a problem. But on the other hand, overdiagnosis is also a problem, because both, as researchers have shown through empirical evidence and through anecdotal evidence, there are often college students who will seek out ADHD diagnoses in order to facilitate or improve the ease of their access to prescription stimulants. Because access to prescription stimulants improves their own ability to engage in non-medical use, but also allows them to sell or share those medications on college campuses, which are all incentives, right? On top of that, access to ADHD diagnosis also virtually guarantees, in today's environment, accommodations in the academic settings. This includes things like additional time for assessments, isolated testing environments, so on and so forth, which are particularly incentivizing in today's hyper-competitive college atmospheres. So knowing that, we have noticed that feigning or malingering ADHD, which means exaggerating your symptoms of ADHD during a clinical encounter for the sole purpose of obtaining prescription stimulants or the purpose of obtaining an ADHD diagnosis, is actually fairly easy. Studies have repeatedly shown that individuals that are trying to fake ADHD don't even need training to do so. They can simply go participate in a clinical encounter, and they know the symptoms are the words they need to say in order to let the clinician think that they have ADHD, right? Current research shows the prevalence of ADHD malingering can be anywhere from 10% to 50%. Again, a wide estimate, but as you can imagine, these estimates are really difficult to get a valid number for. So we do have a wide estimate out there right now. But let me introduce you guys to another tool here for helping improve validity of estimation of ADHD diagnosis, This tool is called Subtle Scales. And we'll begin with a definition here from 1978 by Burkhardt and colleagues. Subtlety in scale development was defined as the degree to which the psychopathological meaning of an item can be determined in an a priori fashion. What I mean when we say that is these clinical assessment tools and scales where we ask questions often are very apparent as to what they are trying to measure. But when you write questions and scales and instruments where the goal of measurement is hidden or subtle, those scales are called subtle scales. The goal of these subtle scales is often to identify if the individuals are malingering or exaggerating symptoms and to capture behavior that is not immediately apparent from reading those questions, right? These scales are not particularly new. They've been around since the 1940s when the Minnesota Multiphasic Personality Inventory and then the McAndrew scale and the substance abuse subtle screening inventory have all applied it. Now, these three scales have used it for identifying malingering of drug use, not mental health conditions such as ADHD, but especially the McAndrew scale and the SASI were written specifically for drug use. And while these scales were not specifically designed for identifying malingering of ADHD, many studies have actually administered them to individuals that were instructed to exaggerate ADHD symptoms to see if the scales are any good at identifying them. Typically, these studies have found that these scales and other existing ADHD self-report scales are not very good at identifying malingering of ADHD. In fact, the only scales that were somewhat good at identifying these were symptom validity indexes, and these scales often are things such as these functional impairment testing, like the word memory test, for example, and they often either take too much time or are not super easy to interpret, particularly in the primary care setting. So having given you guys this context, I want to share that one of our studies we conducted a few years ago now was the development of a new subtle scale that is specifically tailored to identify exaggeration of ADHD symptoms and not other medical conditions. We were hoping that tailoring the scale for ADHD will allow us to show better psychometric properties than anything that is existing in the current research today. So as we set out to develop the scale, we had a few goals in mind. We wanted a scale that was short, that was grounded in theory, a scale that was easy for administration and scoring by the clinician. We wanted a scale that was self-administered and ideal for a primary care environment because we have seen repeatedly that among college students seeking ADHD diagnoses, going to a primary care provider as opposed to a specialist or a mental health provider was common. So our scale was developed with the goal of administration in the primary care setting. And we also developed it in the college enrolled young adult population because we imagined that that is where it has the most application in the future. I'm not going to walk you guys through the methodology of the development of the scale because I think it is a little complex and outside of the scope of this presentation. I want to use our time to talk about recommendations at the back end. But I will say that we published in 2019 a paper in the journal Assessment about a new scale called the Subtle ADHD Malingering Screener. We abbreviated that to the SAMS. That we found had really good psychometric properties for identifying malingering. It had 10 items, 6 questions in the psychological factor and 4 questions in the academic factor. The reliability for these subscales were very good, ranging from 0.909 to 0.916. And both factors actually significantly differentiated honest respondents with and without ADHD from individuals that we had specifically instructed to exaggerate ADHD symptoms. Here is the AUC graph that we published in our paper in Assessment. It had an area under the curve over 90%, which I think is really good compared to both research that was published before this and since, actually. We have a classification algorithm that we identified using CART analysis, and we found that the sensitivity of this scale for identifying malingering was over 90%. And the specificity for the scale was over 80%. Again, both numbers that are much, much better than studies that have been published before our paper and even since our paper up to this date. In a subsequent study, we administered the SAMS to a population of college students picking up a prescription for stimulant medication at the campus health services at the University of Mississippi. We administered it to about 88 individuals who were picking up stimulant prescriptions, and we found that 55% of them were classified by the SAMS as exaggerating symptoms. It's important to note that we didn't actually conduct a clinical assessment of these individuals. We only administered the SAMS because this was done at the setting of the campus pharmacy. But we did find that the prevalence of symptom exaggeration was higher in the group that self-reported non-medical use when compared to the group that did not self-report non-medical use. Now, this difference was not statistically significant because our sample size was still fairly small, but I think this is a significant finding that needs further research. Having said that, our scale, the SAMS, is not the only scale that was developed for identifying malingering of ADHD. Just last year, Potts and colleagues published a new scale called the multi-dimensional ADHD rating scale that was also tailored for identifying malingering of ADHD. Now, the one thing about the MARS that I think makes it somewhat superior to the SAMS is that the MARS specifically has indexes for diagnosing ADHD and diagnosing malingering, both separate from each other. Compared to that, the SAMS only does diagnosing malingering, does not actually do diagnosing ADHD. But the MARS itself has 18 symptom-related questions, 22 impairment and symptom validity items. They're all measured on a scale from 0 to 8. It has several indexes, the inattention index, the hyperactivity impulsivity index, the total symptom index, which is just the sum of the previous two indices, the functional impairment index, and 2 symptom validity indexes. They conducted their study in 119 individuals, also on a college campus. They found 85.7% sensitivity, 65.7% specificity for ADHD identification. And for identification of malingering, they found 79% sensitivity and 89.7% specificity. All really good numbers compared to what else is out there in the literature. They also conducted a follow-up study with just 68 individuals. There, the identification of malingering was a little less better, I suppose, than the previous development study, with 61% sensitivity and 88% specificity to malingering. Either way, my goal with sharing both of these scales here is to help share awareness that there are tools out there today that are specifically tailored for identifying malingering of ADHD. Having said all of this, let me quickly summarize some implications from our findings and other literature that's out there today. I want to share some future directions, some recommendations, particularly for clinicians conducting ADHD assessments. And then I want to wrap up with some recommendations and leave some time out so that we can all discuss and hopefully do a Q&A. All right, the first thing I want to talk about is prevalence estimation. Estimating prevalence really is the most fundamental of all epidemiologic research, right? Any epidemiologic research cannot be conducted unless we know the prevalence estimate first. But improving the quality of establishing prevalence is very, very important. Even online studies where you send an instruction on the very first page of the survey saying this survey is anonymous, nothing you say on the survey will be shared with others, is not often adequate for preventing dishonest responding, for decreasing social desirability bias. It is very important that we identify the setting and mechanism of assessment of sensitive behaviors like non-medical use of prescription stimulants and think critically about how this affects the validity of the findings. The impact of social desirability bias in self-report of these sensitive behaviors depends on many things. Is the survey being conducted in person? Is an interviewer being present there asking questions? Is it self-administered? Is it a paper-based survey or an online survey? What were the characteristics of the sample, the response rate of the survey? Were individuals given incentives to respond to the survey? And what were the instructions given with respect to anonymity or confidentiality? We can use these randomized response techniques as far as possible in the future, but while evaluating previous literature, having all of these things in your mind is very important. And unless we establish prevalence with confidence, we really cannot assess the effectiveness of any future interventions that decrease this prevalence, right? When it comes to malingering assessments, I want to mention that high quality ADHD assessments are very, very important and should probably be a quality of care indicator. This is particularly important because states like Mississippi, where I live, often have huge challenges with access to mental health care providers, right? And ADHD, which is often being diagnosed in the primary care settings as a result of this access challenges, are low quality ADHD assessments where primary care providers do not have adequate time or the skill sets or training to accurately diagnose ADHD. So it is important to know that there are resources available for identifying malingering in the clinical setting. Both the SAMS and MARS are two potential options that are out there today. I will say, though, that neither of these scales have been tested or administered in the clinical setting. So if you are planning to use this in your own clinics or with your own patients, please do so. Please be careful and use caution while doing so. This is particularly important because when we think about assessing malingering, the first place that I've seen most clinicians go to is that the goal of that assessment is punitive. We want to identify individuals that are lying about ADHD and make sure they don't get their prescriptions, right? And I don't think that should be the goal. When identifying malingering in a primary care setting, the goal should be in identifying individuals that may be exaggerating their symptoms, either unintentionally or because they are not aware of how much they are sharing with the clinician, right? And when we identify this malingering, the goal should be to refer these individuals to additional testing, refer them to a specialist, conduct additional clinical assessments for these individuals. And it is also important to remember that when you see a young adult who was not previously diagnosed with ADHD come in and report those symptoms, these may simply be a reflection of underlying undiagnosed mental health issues. ADHD is often comorbid with other conditions like anxiety, and the pressures of a college and academic setting result in individuals coming to a clinician to report these symptoms, and they may not be malingering as much as trying to seek help for their issues. And it is important for a clinician to spend time accurately rule out other conditions before diagnosing somebody with ADHD. Looking at recently published literature that have suggested recommendations for directions for preventing NMUPS, I think it is important to approach this problem from a prevention perspective, not from a treatment perspective, because there is not many sound options out there for treating individuals with substance use disorder for stimulant medications, right? So taking that prevention approach is very important. Part of that prevention approach is making sure that ADHD assessments are high quality. They include multi-methods and multi-informant. Multi-informant meaning obtaining symptom reports, not just from the individual themselves, but from other third parties that may be able to report on that individual's behavior. Prevention efforts should focus on the high-risk population, specifically college-enrolled young adults, but we are increasingly seeing this happen in the later stages of high school as well. Addressing access to non-medical use by making sure there are not inappropriate prescriptions for stimulant medications is important, and any multi-component interventions that can be placed on campuses should make sure that they incorporate validating diagnoses, using specialists, and increasing access to mental health care providers, exploring non-pharmacological treatment options, including motivational interviewing, including things like yoga or meditation, for example, are all non-pharmacological options that have been shown to have some mixed efficacy in the recent literature, but those should at least be explored. Using routine follow-ups and deprescribing when medications are not necessary should all be part of these multi-component interventions in order to be effective. It is also important to address drug diversion on college campuses. Access to prescription stimulants is a critical point in the pipeline for non-medical use of prescription stimulants, but it is important to know that diversion on college campuses does not really look like selling drugs. It looks like sharing medications with somebody else that you're sharing a dorm with, right? And that is an important distinction, because this is not a problem that can be solved by posting a cop outside every dorm room on every campus in the United States. That is not how we are going to solve this problem. Instead, we need to appeal to better education. We need to have better incentives for discouraging drug diversion. And we need to make sure that inappropriate prescriptions shouldn't be floating out there. And in this context of campuses and college students, it is important to know that the college environment has a lot of stressors, especially in rural settings like Mississippi, where individuals move to college from whatever small town they're in. They are exposed to academic stressors, social stressors, financial stressors, because they're taking on huge loans to go through college. And most students, when they come to college, are not very well equipped to handle these stressors, which in turn leads to poor coping behaviors, uninformed decision-making. And it is important to know that individuals working as faculty on these campuses, individuals like me who are professors, are all a part of this ecosystem, right? These hyper-competitive college environments today need more holistic solutions than simply decrease prescribing of stimulant medications and we'll fix the problem, or post cops outside every dorm and we'll fix the problem. I think we need to think about more holistic solutions on college campuses. Obviously, the stressors that I talked about, including the academic and financial, we cannot eliminate these stressors. But as clinicians, thinking about education, thinking about coping strategies, thinking about medication is important. And that is where I think we need to be tailoring our interventions. There is one recent study published by Weiss and colleagues in 2022 that actually makes really good arguments about academic accommodations. I think this paper came out maybe 3 months ago. They make a really good argument about the accommodations we provide on college campuses. Many of these are legally required as part of the American Disabilities Act, but they make the argument, and they've backed this argument up very well, with the fact that these accommodations have moved away from evidence-based provisions to to a system where we want to be providing these accommodations to individuals, sometimes even without the necessary evidence that functional limitations exist, right? So they recommend that psychologists must aim when they are conducting ADHD diagnoses to also assess real-world functional limitations to determine which accommodations are necessary and helpful for an individual. There is inadequate research on how these accommodations actually help individuals without ADHD and individuals with ADHD that may have some types of functional impairments, but not some others. But they recommend that psychologists use any of these three existing assessments, for example, for identifying what kind of disabilities an individual actually has. These include the Behavioral Assessment System for Children, the Barkley Functional Impairment Scale, and the World Health Organization's Disability Assessment Schedule. I think the first two are more popular here, but any of these three are a great first step to begin to assess and make sure there is a lot of transparency in reports for ADHD assessment. So I want to conclude by saying that ADHD and non-medical use of prescription stimulants is a very complex problem, but it is important that we talk about it, share awareness about this problem, because this is an issue that is going to require a lot more research going forward. There is a very complex balance here between underdiagnosis, undertreatment, and overdiagnosis and overprescribing. And it requires nuance to make sure that individuals that actually need treatment and care still receive it, but at the same time, we are properly addressing non-medical use and the sequelae that come from that non-medical use. Just like we saw with opioids, broad restrictions on access to these prescriptions may end up resulting in outlets that are more harmful than non-medical use of prescription stimulants. So I'm by no means suggesting that we go in that direction, but addressing non-medical use will improve holistic solutions on campuses and improving access to high quality mental health services and destigmatizing mental health issues among young adults. I will say that the research I've presented today were by no means my own. There is a whole village that has been here helping me conduct some of these things. And here are some names of some of my collaborators over the years that have helped in various studies that I've presented today. My contact information is also listed here, including my email. Please reach out if you want to share any of your thoughts. If you have any comments or questions, I'm happy to share the scales for the SAMs if that is something you're interested to work on. But I see that we are about 44 minutes into the presentation. So I'm going to stop here and see if anybody has questions.
All right. Thank you, Dr. Ramachandran. We do have, it looks like a couple questions posted in the chat. The first one is, how do you help a person whom has addiction like meth or cocaine and after sobriety they have anxiety or ADHD symptoms?
That is a very good question. The co-occurrence of substance use disorder conditions along with ADHD or anxiety is a very challenging issue. I will say that the substance use disorder population is quite different from the college age young adults that we have discussed today. Having said that, I am not a clinician, so I am not going to recommend a certain treatment strategy for these individuals, but I will say that it is very difficult to make sure that we draw a careful line between making sure we don't overprescribe and underprescribe, right? And this population in that question with the substance use disorder is not a population that I would be comfortable removing treatment access from. And when I say that, I particularly mean treatment for substance use disorder, but treatment of ADHD in this population is also another challenge that I think is a whole different world out there. I, as not being a clinician, cannot make a recommendation on that part.
The next question is, I've had clients tell me they took a long test, approximately a 3-hour test, to get an ADD, ADHD diagnosis. What test is that?
Yeah, there are a whole host of tests out there that I think a clinical psychologist might use that take 3 hours or sometimes longer. Usually these include functional impairment tests like the word memory test and the symptom validity assessments. Now, these tests are currently considered the gold standard for diagnosing ADHD. And I will say that they are more robust than anything else that is out there. In fact, the subtle scales I presented, like the SAMs and the MARS, are often not the best way to confirm ADHD diagnoses. These longer symptom validity assessments and functional impairment assessments are better at doing those. The problem, however, with those tests is that they are not easy to administer, they are expensive, they are time consuming, and most primary care clinicians do not have the training to even administer these things, right? I think that's where we've seen the demand in the research literature for developing some of these subtle scales that are tailored for ADHD assessments. In my opinion, those longer tests are the gold standard and should continue to be the gold standard for ADHD assessment.
We have participants that are interested in having the SAMs. Maybe we could include that in our follow-up to all participants. We're going to include the slides. We can include that as well. And then there's a statement in here that says there are non-stimulant prescription medications to treat ADHD, which we often recommend for those with substance use disorders.
That is a great point. I agree. There are non-stimulant prescription medications as well. Those non-stimulant medications, there is mixed evidence on how effective those are. One of the things that I've always suggested as being a great idea for newly diagnosed individuals with ADHD is to conduct an N of 1 trial, right? I don't know if you guys have been exposed to these N of 1 trial options before, but they basically involve a clinical pharmacist working with the individual newly diagnosed with ADHD to blind them to treatment options and give them a placebo for a few weeks and then switch to a stimulant medication for a few weeks. And now the individual will not know which one they're getting first because you randomize which one they get first. But this blinding and randomization allows individuals to see for themselves how their symptoms are improving, how they are coping with their own ADHD conditions, and then ask themselves if a stimulant medication is necessary for their treatment, right? Stimulants have enough side effects that even individuals with ADHD don't want to be taking them if they don't have to be. So doing those N of 1 trials to help individuals determine which treatment option is ideal for them is more time consuming, elaborate, but in the end of the day, might be the better approach for deciding who needs a prescription and who does not.
Are there any other questions?
If anybody has thoughts, comments on anything I've shared today, I'm happy to hear them. If you guys want to work on research and work with us to further this stream of research, I'm happy to facilitate that as well. Please feel free to reach out to me.
Could I ask a question?
Of course.
Hi, my name is Lori Shulman. I'm a social worker and my private practice is Caven Counseling. I just wanted to add in my experience and also my personal experience in working with clients, psychosocial history is very helpful too for the gold standard because of the issues with attention that come up with teachers, no matter how old the person is being assessed. I think behavioral issues growing up, difficulty with following instructions is also like super helpful. That's all. Thank you so much for the presentation.
Thank you. Thank you.
All right, any other questions or comments?
I would like to ask a statement question. What you said about the ADHD and then the separation from SUDs and stuff like that. Sometimes I work with people that have this SUDs real heavily, but it's like there's always some kind of underlying cause of that. And I'm just wondering how many that I know once they're in the problems with the drugs, they can't really go back to the old underneath it, but how would you separate it so that they could find out that maybe that's their base causes the other issues rather than the SUDs? Does that make sense? And it's more like a self-medication process.
I see what you're saying. The problems with self-medication have been reported in the recent literature as well. It's basically this issue of individuals sharing or sharing or taking their friend's stimulant medication and then finding out, hey, this helps me, I must have ADHD as well, right? And then that they go down that road of self-medication frequently enough that at some point they realize, okay, maybe I need to go to a doctor and see if I actually have those symptoms. And that's where these ADHD assessments become very challenging, I believe, right? Because when students that have been self-medicating with Adderall or Ritalin, then go to the provider, they know the symptoms of ADHD that they should be saying, and the symptoms they report may be a product of their withdrawal from the self-medication. But it may also be that they actually have underlying ADHD, and finding the balance between those two things is very, very challenging. I think what we need at that point is to make sure that clinicians can provide their patients the safe space they need to actually share their self-medication behavior history, and begin with that before conducting further ADHD assessments. This is a challenging issue. I do think we need more research in this area, but given the challenges with access to mental health care providers. So for example, in the state of Mississippi, the county I live in and the surrounding 3 or 4 counties all together have maybe 4 or 5 clinical psychologists, right, for access to care. I think we begin with that issue with having adequate access to care, but there are certain challenging issues that need to be addressed even beyond that, I think. And I think that is a great comment you've made. I hope that addressed it, but I think these are more complex issues than research that we've conducted completely gets at even. I'm seeing a great comment in the chat as well. Very important to treat mental health and substance use disorder at the same time. Absolutely. Didn't know many in grad school that were using Adderall. Yeah. It is amazing to me how many people we've interviewed that are college students that will share that they are willing to use Adderall from their friends, their colleagues, buy it from the street for $5, $10 a pill. Despite that, I do think there is significant social desirability bias in these surveys. But once you get students in a safe space where you can express to them that they can share this information and be anonymous with any sensitive behaviors, it is incredible the information they will share. I have encountered individuals that have talked about how they trained some of their friends and themselves to report the right symptoms to get an ADHD diagnosis from a clinician. And then driving to the right doctor in town who they know will write a prescription for them, as opposed to just going to anybody, right? So there is a network of this training, if you will, that happens on college campuses as well. And finding solutions for behavior like that is not going to be straightforward.
There's a question in the chat that says, how does Vyvanse differ from Adderall in treating ADHD?
I don't think they differ per se. Both Vyvanse and Adderall are stimulant medications that are controlled substances that are the same class of medications. They're psychostimulants. I have found that individuals that have ADHD often need to go through a trial process, if you will, where they go through medications and figure out which exact drug and which exact dosage is right for them. I do not believe there is a significant difference in terms of abuse potential or in terms of side effects or in terms of efficacy even between Vyvanse and Adderall.
What are your thoughts on the role of social media and stimulant use? We've been seeing trends on TikTok and YouTube of self-diagnosis of ADHD.
That is a great question. I cannot tell you all how much I hate somebody coming up to me and saying, oh, everybody has a little bit of ADHD. I think that trend on social media is one that I particularly hate, because it also minimizes the struggle that people with ADHD actually face, right? It not only leads to this overdiagnosis, it minimizes the struggle that people that actually have the condition experience. So I do not like that. But as with other things, it is not possible to control what we see in social media. What we can do is make sure that when students get to a college campus, when we have these freshmen come in, we make sure that they are educated correctly, that they are given the right information to facilitate better decision making. Because saying everybody has a little ADHD may not be harmful if individuals still are treated the right way, if they still make the correct decisions when it comes to the day before the exam and they need to, study a lot of material to make their grades. I do think social media plays a little bit of a part in this, but I think the solutions perhaps are beyond social media, which is that instead of restricting what happens on social media, we need to make sure there is adequate access. We need to teach better coping behaviors for these freshmen that just get to college campuses. And that education may also happen on social media, right? So there can be a clinical account making TikTok videos or tweets or whatever it takes, sharing accurate and correct information about ADHD and symptoms and treatment to kind of counter some of that misinformation that we see out there. I want to say one more time before we wrap up, I thank you again for the Michigan Opioid Collaborative for having me on here. I've really enjoyed talking to you all. These have been great questions, and I appreciate the opportunity and hope to keep this dialogue going. Please feel free to email me. I'm on Twitter. You should be able to look me up on Twitter or LinkedIn, and my email was on the slides that I will share with you all soon. So please reach out. I'm happy to engage in this discussion further as well.
All right, thank you so much, Dr. Ramachandran. Again, we've posted the PDF with the QR code and survey links for credits in the chat a few times here today, but we will also email it out to you in the coming days so you have access to it as well. Thank you all for being here, and we look forward to seeing you next time. Have a great weekend.
Thank you all.